Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled Key Viral Hepatitis Studies Influencing My Practice Following AASLD 2022. During this podcast, Dr. Stefan Zeuzem, Professor of Medicine and Chief in the Department of Medicine I at J.W. Goethe University Hospital in Frankfurt, Germany, discusses new viral hepatitis data related to hepatitis B, hepatitis delta, and hepatitis C. For more information about Dr. Zeuzem and for a link to the full online educational program, including downloadable slides, please visit the links in the show notes for this episode. Now, let's get started and hear what Dr. Zeuzem has to say about new viral hepatitis data from AASLD 2022.
Hello to everybody on the program. AASLD just ended yesterday, and it was a big effort, and thanks to CCO to have prepared key slides on the key presentations on viral hepatitis. I will walk you through, I think, quite a number of important studies in the B, delta, and C field. Let's start with hepatitis B. So this is the question which was asked many times, but here now in a very large study, how to prevent HBV vertical transmission from pregnant women with HBV DNA levels above 200,000 international units per ml. And the question these authors asked was whether the amount of 300 milligrams of tenofovir from the gestational week 14 to 16 to delivery was sufficient when infants received only 10 micrograms of HBV vaccine after delivery. The second group to which the pregnant women were randomized received tenofovir from gestational week 28 to delivery, and then the infants received both an active and passive immune protection by the active vaccine and 100 IUs of HBIg, which is antibodies against the HBs antigen. The endpoints were the rates of congenital defects and the rates of mother-to-child transmission. And here are the data. The number of congenital defects seem to be very similar. In the experimental group, they were numerically slightly lower, but not statistically significant. Some children still at delivery, at birth, had still HBs antigen positivity in the range of 15 to 16% in both groups, but all infants were HBV DNA negative. And at week 28, this is the final endpoint, the vaccine-only group had zero HBs antigen, zero HBV DNA levels detectable, as did the control group. So in circumstances where the HBIg is not available and you are able to initiate tenofovir treatment early enough in the pregnancy, it is dispensable. But we all agree in Western countries where the HBIg is available in the majority of hospitals that the preferred mode, despite these data, remains the standard of care for children. So mothers at high viral load should receive tenofovir early on in the second trimester, and children should be vaccinated actively and passively. But these data are very important for countries where HBIg is too expensive or unavailable. And I think this is good news, especially for less developed countries where HBIg is typically not available. Then we see quite a bit of an activity on the development of therapeutic vaccines. This is very early work in animals, so we shouldn't have too much time on it. But there are now novel alternating vector therapeutic vaccines for hepatitis B, which really exhibit very robust T-cell and antibody response across all genotypes. And there were some animal studies here performed by Gilead Sciences showing that there is a substantial T-cell and antibody response with these therapeutic vaccines within a 4-week dosing period. And HBV-specific T-cell responses were further enhanced by each additional dose. Both vaccines which were investigated showed HBV-specific immune responses, primarily mediated by the CD8 T cells. The CD4 T cell response was accompanied by a high magnitude polyfunctional CD8 T cells, and a therapeutic vaccine with higher titer immune responses may be an additive attractive option as an immune-enhancing partner to antiviral therapy. I like to mention that because all those developments we have seen currently with nukes, with so-called CAM inhibitors, actually did not lead to HBs antigen elimination. And it's probably only the siRNA technology and the therapeutic vaccines which are potentially able to achieve this aim of HBs zero conversion, a functional cure in our patients. But these antibodies I just mentioned, interesting data, but they have not yet been investigated in humans. Big question is about the risk of patients who do not fit into any of our standard categories. You have all in your clinic patients which do not fulfill the criteria of really low replicative chronic hepatitis B. They occasionally have higher than 2,000 IU per ml HBV DNA. They occasionally have or constantly have elevated ALT levels, but they really do not fit into the category where we would say this is a clear high replicative indication for antiviral therapy. So it's an indeterminate phase, and physicians typically react very differently because there is little data around what kind of risk these patients have, whether or not they receive an antiviral therapy. And the question here was not the reason or the risk that patients decompensate. It was really, which is very unlikely in this population, but this patient population is at risk to develop HCC. And the question these authors actually tried to answer was whether patients who are in this group of indeterminate phase benefit from treatment with direct antivirals with respect to their risk of HCC development. And you see here the 5-year incidence, the 10-year incidence, and the 15 years incidence. And treatment of these indeterminate patients for the first 5 years did not show any difference with respect to the incidence of HCC. However, already at the 10-year incidence, there was a striking difference between 14.7 versus 3.9% out of the untreated and the treated groups. And this difference even got more pronounced after 15 years of follow-up in those patients. So apparently a longer treatment, actually longer follow-up in patients who are treated, give a significant benefit in terms of cumulative risk of HCC. These are further multivariate analysis from this study. You see that patients with an ALT, which is actually normal, showed that untreated, even with a normal ALT, continued to be at risk for an HCC. And this is quite significant. So please, in your clinical practice, don't make your decision too much based on ALT levels because they are not really predictive. Keep in mind that especially cirrhotic patients, compensated cirrhotic patients, can have rather low ALT levels, and this may lead actually to the significant risk of development of HCC in this group of indeterminate patients with chronic hepatitis B infection. So my take-home points for hepatitis B is that early maternal TDF treatment and infant HBV vaccination are feasible, simplified approach to prevent mother-to-child transmission. We should still prefer in countries where both vaccination, active and passive, are available, should keep this practice. But in countries with less access, we have clearly the possibility to keep out the HBIg with similar results in this trial. In patients with chronic hepatitis B, in the intermittent phase, antiviral therapy was associated with a significant reduction in the risk of HCC after 5 years. There is potential for expansion of treatment criteria to patients with chronic hepatitis B in this indeterminate phase. Cost effectiveness, however, has not been evaluated, but cost effective is, of course, a very different approach in different countries. And the therapeutic vaccines make progress, and these therapeutic vaccines should be followed as part of antiviral strategies for hepatitis B in the near future. Delta is very exciting. We have new drugs on the front coming up, and therefore it's very important to get an insight into the real epidemiology. And this is a study from the United States comparing two different healthcare systems. This is once an urban safety net health care system, and this is compared to the Veteran Affairs healthcare system, which of course is a much larger and global US registry. And the question the authors here asked is the proportion of patients who were actually tested for HDV by the currently available HDV methods. This is just the baseline characteristics. Not surprising that in the Veteran Affairs population there were almost exclusively male, more Black people, less Asian people, more non-Hispanic white people, less HIV co-infected patients, however, more patients with liver cirrhosis. But if you see the rate of HDV testing, this is, I would say, actually both groups suboptimal. It was just about 20% in the Veteran Affairs healthcare system and 30% in the urban safety net health system. So what we really need is much better awareness that all HBs antigen carriers need anti-HDV testing, ideally by reflex testing. And of course, anti-HDV positive patients require HDV RNA assessment. However, I realized that this is only feasible in the United States by one of the larger labs. And this is still a challenge in many countries around the world to obtain HDV RNA measurements. This is some further analysis of the study. So, for example, in the Veteran Affairs healthcare system, Asian and Hispanic patients were more likely to be tested than non-Hispanic white patients. And there is no reason for this. Risk-based testing for Delta is not the way forward. What we have to do is universal testing for all HBs antigen carriers. So I skipped the other comments because indeed the takeaway is that we have to come off those risk-based testing strategies and enter universal testing for anti-HDV in all HBs antigen positive patients. Why should we do that? We should do it because Delta hepatitis has a more advanced and more accelerated course of disease. Patients more likely to develop cirrhosis, to develop cancer, to require transplant. And there is now treatment upcoming. This treatment is currently only available in Europe, but should be available in the next year also in the United States. And we have here an prospective, retrospective observational studies in Delta patients from the French ATU program. And it was not a randomized study. It was at the discretion of the physician whether he wanted to treat a patient with Bulevirtide as monotherapy, 2 milligrams subcutaneously QD, or whether he wanted to combine therapy with Bulevirtide 2 milligrams together with PEG interferon alpha 2A subcutaneously given once weekly. And the physicians also had at their discretion the decision whether or not to stop therapy after 12 or 18 months or to continue treatment to months 24. So full 2-year treatment was possible in this ATU program. If you now look here at the combined effect, you see in the blue column the combined effect, which is defined as HDV RNA decline to more than 2 logs or undetectability, and also normalization of ALT levels. In blue, you see the Bulevirtide alone. In red, the combination. And the green one is the Bulevirtide plus pegylated interferon, but in the second phase of therapy, continuing treatment after a year only with Bulevirtide. If you see initially in the month 12, apparently the combined response was better with Bulevirtide alone, but looking over time, you see that indeed in all three treatment categories, the rates of combined effect actually became pretty similar in the range of 41 to 52%. It's interesting to look only on the on-treatment virologic response, and here you see clearly that the addition of pegylated interferon to Bulevirtide has a much better initial antiviral response. So if you compare the red and the green column, where pegylated interferon was given on top of Bulevirtide in the first year, to Bulevirtide alone, the virologic response rates were twice or even 3 times higher than Bulevirtide alone. But very interesting, and this is one of the key findings and messages of the whole AASLD 2022, is that after 24 months, the response actually became pretty similar. So the Bulevirtide monotherapy treated patient actually catched up, and there was, in terms of antiviral response, not much of a difference between the three treatment strategies, which is now, of course, questioning the value of adding interferon overall if you would have the possibility to treat with Bulevirtide long enough here for 24 months. There are a few further analyses, and the key message here is only that the prediction in multivariate analysis, the only prediction of achieving the endpoint is the on-treatment HDV RNA decrease by more than 2 logs at month 3. You remember we had a similar level and threshold in hepatitis C. When we treated hepatitis C still with pegylated interferon, we also had the 2-log decline as a futility rule. Whether this becomes a futility rule also in Delta is too early to say, but we can already say that patients who respond with more than 2-log at month 3 have the best chances to achieve the relevant endpoints. This study was further supported by an Italian study. Here, almost 100 patients, 93 patients were treated with Bulevirtide 2 milligrams. And I just show you here the antiviral responses in this population, which is granulated according to the threshold of HDV RNA. So you here see really less than 6 IUs per ml, which probably comes close to undetectability. You have less than 100 and less than 1,000. And you see at week 72 of treatment that according to the viral threshold, the rates of response, virologic response varies. So if you take a very strict definition, HDV RNA less than 6 IUs per ml, you achieve 38% negativity in these patients. However, if your aim is just to come below 1,000, you can see that this is achieved in 4 out of 5 patients, 81%. Important that if you block with Bulevirtide the entry receptor, the NTCP receptor, that you see a significant increase in serum of bile acids, but this is not associated with any side effects and not associated with pruritus. The lonafarnib I don't want to cover in detail due to time constraints. There were some data shown in a study of 5 patients, and I don't want to go here into the detail. I just want to show you those 2 patients which achieved with lonafarnib-based therapy a functional cure. And the treatment was in one case by lonafarnib alone, given 300 milligrams BID. And it was also achieved in a single patient with 100 milligrams lonafarnib combined with 50 milligrams of ritonavir. Why is ritonavir given? We know that the high dose of lonafarnib is causing quite substantial GI side effects, and these are typically linked to the maximum peak level of the drug in serum. So to avoid this and to keep the half-life long enough, the pharmacokinetic optimization is done with a lower lonafarnib dose together with 50 milligrams ritonavir given BID. And it's quite promising that individual patients achieved functional cure. So take-home messages here are that we have to improve HDV testing rates in every circumstances, certainly in our practice, our own personal practice, and even large organizations lack optimal testing proportions. Double reflex testing must be promoted, as I mentioned a couple of times, and the risk-based screening is underutilized. Different screening strategies are needed. I say every HBs antigen positive patient needs the Delta antibody test. Bulevirtide monotherapy demonstrated similar efficacy to Bulevirtide combined with pegylated interferon alpha-2A. If you look after 2 years of therapy, and in patients with compensated cirrhosis, Bulevirtide was associated with an increased virological and biochemical response over time out to week 72. Potential on-treatment and long-term off-treatment benefits on lonafarnib. And here I like to make a very important point that Eiger, the company who is manufacturing lonafarnib, is going to announce the data of one of the largest, if not the largest, Delta phase 3 study ever performed in this population. Data are completed, data are currently analyzed, and we expect a press release from the company in early December this year. So this will see whether we have, in addition to Bulevirtide, a second viable drug. And if this would be the case, we would, of course, be very interested in combining both drugs in the near future. Let's see. A few words on hepatitis C. We have here another study from the UK looking into innovative strategies for linkage to care. This is prospective study divided into 2 periods, and the outcome, the primary outcome, was the ITT sustained virologic response rate with emphasis on the recruitment period. The period 1 was from 2013 to 2017, and the second recruitment period was from December 2017 to 2021. And interestingly is, or I would say it's not really surprising that whatever analyses you do, you achieve very high sustained virologic response rates. But the interesting point here is that the efficacy in the second period somehow declined, very small delta, but we would rather like to see an increase, but it declined slightly. And this was mainly linked to the adherence factor. And probably this whole reflects that the patients we are treating in this population get more and more difficult because they have more social circumstances which have lower accessibility to these patients, lower linkage, and lower adherence. So more efforts probably from the social and the psychological side are needed really to keep and get those patients into treatment and achieve viral eradication. They did also, for this study group, subtype analysis. And here I like to show this to you, not because there was any surprise in the last 2 columns on the right side that low adherence leads to very low sustained virologic response rate. No, I like to show to you that the use of OAT had an impact of lower sustained virologic response rates. And really interestingly, that patients who received ribavirin did actually better. And therefore, these are the key messages. Ribavirin is still in the game, potentially in this population. A good substitution helps the patients to be adherent to the treatment. And of course, you have to take the drugs and the pills to achieve a sustained virologic response. And another important number was the 7.5% reinfection in this population, which is more or less in the range of what has been published in other studies, Australia, United States. Generally, you have to expect less than 10% of reinfection. And also worth noting is that this is a high-risk population in terms of mortality. And it's very sad to see that the mortality rate in this population across all patients was above 10%, not linked to the treatment, not necessarily linked to the hepatitis C infection, but certainly to all the other problems linked with drug use. The other study I like to share with you is a study looking into the question whether hepatitis C needs to be treated by specialists. Here we have a comparison of treatment in an addiction center, and these patients were directly treated by a non-specialist, and this was compared to patients followed in a referent hospital and directly treated by a specialist. And overall, of course, the results are excellent, but important to note that the non-specialists did exceedingly well. 100% of patients achieved a sustained virologic response, and therefore we should probably move this treatment if we really want to eradicate hepatitis C in our region, our country. We have to move the treatment to general practitioners, nurses, if possible, legally possible in your country. There is no reason that non-specialists should not be able to cure hepatitis C patients. For time constraints, I like to skip this one because I would like to have a little bit of time to spend with you on the risk of hepatocellular carcinoma after SVR, because that's a practical question we have every day in our clinic. It's a clear recommendation to continue lifelong surveillance for HCC in cirrhotic patients, even after viral eradication. And this is just another detailed studies performed in Japan to see what the risk of HCC is in this population. So here they have a kind of risk patient population, and they looked 1 year, 2 years, 3 years, up to 6 years after achieving sustained virologic response in their patients they cured. And you see that overall the HCC occurrence rate is low. It's in the range of 2.5% after 5 years. So the question is, whom should we keep on surveillance, and is this a continuously rising risk, or is it going to become a plateau that you can safely stop the surveillance after sometimes, like, for example, 5 years? And they did a multivariate analysis on the predictors of HCC occurrence. And clearly, the older age was definitely linked for a higher risk of developing an HCC, increased ALT level after achieving sustained virologic response, indicating some comorbidity, co-infection, NASH, or whatever, was linked to a higher HCC incidence over time, and the alpha-fetoprotein level, not at baseline when the patient started treatment, but at the end of the follow-up period after treatment, was a clear predictor of achieving an HCC or developing an HCC over the next years. The total bilirubin and albumin levels were predictors only in the univariate analysis, but did not hold up for the multivariate analysis. So they come up with a very simple score, which I think is easily applicable by every colleague also in general practice. If you would give for age, ALT at sustained virologic response, and alpha-fetoprotein just a score of 1, and you could remember it as the 3A score, you see that those patients who have a score of 2 or 3 points, so 2 of the 3 risk factors mentioned in the table, that these patients have a risk of almost 5%, while if you have a score of 0, there is virtually also a 0 risk of developing HCC. And I would have liked to see also included the question whether patients have diabetes, because in many other studies, the diabetes comes out as a risk factor for developing HCC, but it may be included in the ALT level at the end of the follow-up people, because diabetic patients, and especially not well-controlled patients with diabetes, tend to have a little bit of NASH, tend to have slightly elevated ALT levels. So this risk group may be somehow included in this category of elevated ALT after the follow-up period, after achieving sustained virologic response. So we clearly have to get along with all those patients in follow-up we have cured. And the point we want to make here is that perhaps scores are going to help us. We also want to make the point that the risk of developing HCC after SVR is somewhat declining. I mentioned already the other factor I think is important, the diabetes. And we should, however, keep in mind that other large studies need to be performed really to finalize the recommendations, which patients should be followed with HCC surveillance for how long. These are just some data from the Veterans Administration in the way supporting this. In patients with cirrhosis, time since SVR was associated with a declining risk of HCC, but again, we need better predictors for those patients where we can really stop treatment, stop surveillance, and for those where we have to continue. This is just experience in one or a large cohort, and it needs to be confirmed furthermore to get implemented into our guidelines. So take-home messages for the hepatitis C field is that high SVR rates can be achieved in complex patient populations. High SVR rates can be achieved with DAA treatment, whether delivered by specialists or non-specialists, and regardless of fibrosis stage. And in patients with HCC without advanced liver fibrosis attaining SVR, the cumulative rate of HCC occurrence is only 1.8% at 3 years and 2.5% at 5 years. And in patients with cirrhosis, time since SVR was independent and associated with a declining risk of HCC. With that, I'd like to hand over back to Sarah, and I hope that we can answer as many questions as possible in the remaining couple of minutes. Thank you very much.
Wonderful. And thanks to you, Dr. Zeuzem, for that excellent presentation. We've had a number of questions come in from our audience members, and we'll go through, like you said, as many as we can now. So I'm going to take us back to hepatitis B and the Real B study because we had some interesting questions that go together. So Steve asked, do you make firm recommendations to treat HBV in these indeterminate patients based on the data from the Real B study? And then Bob takes it a step further and says, should all of our guidelines, EASL, APOSL, AASLD, the German viral hepatitis guidelines, should we just move to simple guidance and say, treat all hepatitis B DNA positive patients?
So that's one study. And this study is, of course, hinting to a fact that we should be probably more reluctant and treat these indeterminate patients. I don't think that this can be extrapolated for purely patients with low replicative state of chronic hepatitis B. So patients who have HBV DNA levels continuously in the range of 10 to, let's say, 1,000 and have completely normal ALT, I think here we have no evidence whatsoever. But those patients need to be followed, and the number of patients who eventually come into an indeterminate phase is not that low. And in particular, if other risk factors are present with these patients, so family history of HCC development, age, male gender, definitely I would be more in favor to treat those patients early on than to wait much longer. I think we need more data, but clearly the field is moving towards this direction that probably we have to be here a little bit more stringent to avoid further cases of HCC.
Great. Thank you for your thoughts on that question. The next question focuses on hepatitis delta and comes to us from Yusuf, who asks, all guidelines recommend a 1-year duration of hepatitis delta therapy for both pegylated interferon and pegylated interferon with Bulevirtide. Is there any reason to extend the treatment duration if we observe a significant decrease in their surface antigen level and their RNA negativity to up to week 48?
So the point will be the label. You must keep in mind that the French were very free to decide whether they want to treat for 1 or 2 years. But the question is going to be the drug reimbursed for longer than a year? So currently the label in Europe, and it's a provisional label, reads that patients can be treated on Bulevirtide as long as clinical benefit is observed. If this would be in the label all over and globally, you could definitely treat indefinitely longer. And then these French data become very important, because if indeed with treatment for 2 years, the initial antiviral benefit from interferon disappears and vanishes, and this is needs to be confirmed, of course, then I think the reason to start patients combined with pegylated interferon will disappear. So this is a key study. It needs to be confirmed, still small numbers for the 2-year data, but if confirmed, and if you are able to give Bulevirtide for longer than a year, according to your country label, then it's probably the pathway forward to treat our Delta patients.
Great. Thank you for sharing information on that as well. I'll ask you the next question about hepatitis C. So Carmen asks, in the study presented from Japan regarding hepatitis C treatment, the score was developed, so I think referring to that 3A score, to evaluate risk for HCC in patients without advanced fibrosis, since patients with a FIB4 greater than 3.25 were excluded. And they just want to know if that's correct.
That's correct. And the recommendation, I would always continue lifelong to HCC surveillance in cirrhotic patients with hepatitis C. But the question is that there is also a substantial risk of HCC in F3 patients, and the question is whether these can be eliminated. And with these simple scores, it's probably a guidance how you could deal with patients who have not a full-blown cirrhosis, but somewhat advanced fibrosis. And if they have none of these risk factors, the cost effectiveness is probably, and the clinical outcome, probably not justifying to have lifelong surveillance of those patients. However, if they have these elevated ALT levels, if they have diabetes, if they are older, and if they have this slightly elevated alpha-fetoprotein level, I think these are indicators for patients with not so much advanced disease to keep them on a regular surveillance.
Right. I think we have time for one last question about hepatitis B. And this comes to us from Fatma, who asks, if a patient comes in with a recent serology positive for hepatitis B and meets treatment criteria, should we treat this person immediately, or should we wait 6 months to confirm whether it's chronic hepatitis B?
So typically from the history, you can already decide whether it's an acute or chronic hepatitis B. But nevertheless, even in a chronic patients with chronic hepatitis B, I prefer always to have at least 2 values, especially if they are e antigen negative and have not a very high HBV DNA level. So in somebody who, you have a transmission factor 10 years ago, 5 years ago, and he comes into a clinic and is HBe antigen positive and has a couple of millions HBV DNA levels and hundreds of aminotransferases, that's a clear indication you can start him immediately. But the majority of patients coming to our clinic are patients e antigen negative, typically only mildly elevated ALT level, if at all, borderline quite frequently, with an HBV DNA level, let's say, of 10, 20, 30,000. And here I prefer to have a second, sometimes even a third measurements, really to be sure that they belong to a group of high replicative state patients with chronic hepatitis B, and that I'm not just picking up an individual flare which disappears again, and I would do a treatment which would not have been justified because the flare may disappear and the patient comes back to a low replicative stable status of his chronic hepatitis B infection. So if there is time and no clear indication, I always urge and motivate my colleagues to test a second or third time. Patients is not endangered in this situation, but you will have a firm indication for your treatment if you would do that.
Thank you very much to Dr. Zeuzem, and thank you to our listeners for joining in. As a reminder, to view the full AASLD 2022 Viral Hepatitis Conference coverage program on the Clinical Care Options website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.